Good afternoon, everyone, and welcome to this month's CareNext Collective presented to you by Manulife Canada. For those of you joining us for the first time, my name is Danina Kapitanovic. I'm the Vice President of Innovation and Chief Health Innovation Officer at Waterloo Regional Health Network and University of Waterloo. And the collective is our space to explore innovation together across REN, the University of Waterloo, but also our wider ecosystem. Today's focus is really exciting. You will have noticed that we took a bit of a summer break, and we hope that with this month's topic, we're really giving you an exciting start to the fall. So our focus for today's robotics in healthcare. This is no longer science fiction. It's here, it's real, and it's reshaping what's possible. So our objective for today is they are threefold. One, we want to see what robotics can already do across healthcare relevant applications. Two, we want to explore what's holding adoption back and how we can change that. And three, it's to hear from both researchers and system leaders about how we can design for the future right now. So to do that, I am thrilled to welcome two exceptional speakers. Brandon DeHart is manager of the University of Waterloo's RoboHub and adjunct professor at electrical and computer engineering at University of Waterloo, Canada's most advanced robotics facility. Rebecca Stewart is executive director of service planning and operational readiness, directing the REN University redevelopment project, where we are designing and building a new hospital on University of Waterloo campus, a once-in-a-generation opportunity to embed innovation from the ground up. So, Brandon, let's start with you. It would be great if you could give us a sense of what RoboHub is, what makes it unique, and why it matters so much for healthcare innovation. It will be great if you could sort of narrate where what we're seeing here is a short 4-minute video with examples across all segments. So it would be great if you could basically narrate and explain as we go.
Sure, yeah. Hi, folks. Happy to be here. Thanks for inviting me. We'll start with kind of the mobility piece, right? So this is looking at assistive devices. It's looking at exoskeletons. On that front, we also, another piece that we're going to be talking about is human-robot collaboration. So robots that are working actively with people. So you can see this humanoid is carrying a table, or you're kind of handing things back and forth with, this is a mobile manipulator, so arms on legs or arms on wheels. Where you can actually work with these systems. They can carry things, you can hand them off, and generally they can navigate kind of our built environments, so hospitals, long-term care facilities, things like that. And I think one of the key things here is that all of the robots that are shown in this piece have sensors in their joints so that they can tell how hard they push on the world and how hard the world pushes back. So you can kind of very naturally interact with them. The next piece is kind of the logistics aspect. So this would be a follower where you can put whatever kind of equipment or devices, laundry, whatever it might be, into one of these systems. It can follow you. There's also the light card here where basically it will take the weight and the mass. So you can see the researcher is just kind of barely touching that. And then even some autonomous ones where you can give it direction, and something like a bed or a desk or any kind of other logistic system can move around on its own. There's also then kind of the telepresence and remote presence and tele-interaction aspects. So you can see there's someone in the background on a virtual reality headset controlling this arm directly. So you can then interact with things, but the robot itself doesn't need to have that embedded intelligence. There's a human on the other end providing those controls. And it's not just limited to a single arm. You can do dual arm, you can do mobile systems, right? So again, similarly, someone on a VR headset, they're looking out through the eyes of that robot effectively. You can even get kind of further beyond that into something like a humanoid where you're actually remotely controlling the humanoid with a full body setup. So potentially you're in a VR system or even in an exoskeleton where as you move your arms, your legs, your head, that robot is going to do the same. And it's actually the easiest type of system to remotely control is a humanoid because we've all grown up with our human bodies. We know how legs and arms work, how we need to move if we want to pick something up, etc. So we're very familiar with that. Similarly, this robot has torque sensors in the joints, and this setup also has sensors in all the joints, so that you can directly move. It's not the humanoid setup where you're kind of doing that same thing. So you do need a bit of training for those ones, but you can do remote surgery. You can do all kinds of things with that. And then the last piece that I kind of want to introduce is on kind of the precision manipulation and the micro robotics. So we can actually use tools that have been developed for robotics, and they're already being used actually, to specifically locate pieces of a body, joints, bones, muscles, anything like that, for the external of the body, kind of outside. And then there's also in vitro pieces where you can use something like a rotating magnet on the end of a robot arm to direct the motion of a micro robot within the body. So maybe moving through a blood vessel, moving through kind of any of those channels inside the body. So there's lots of different potential there, and many of these things are already actively in use. But all of those examples I showed are things that we're doing currently on campus in Waterloo right now. Oh, and you're muted, Danina.
My goodness, after all this time. Thank you, Brandon. This was really a fascinating and powerful way to see the breadth of possibilities. All of this footage is taken at University of Waterloo, and some of it specifically at RoboHub. So could you give us a sense kind of what RoboHub is before we dived into each of the segments that you've described and for which we've seen the video, kind of what makes the hub unique and why it matters to healthcare innovation?
Yeah, for sure, for sure. So the RoboHub started as a shared research facility across a number of departments within engineering. But very quickly after we built it, and this is kind of a shot of the RoboHub behind me here and some of our robots. Very quickly after it got built, it became one of the most toured destinations on campus. We were supporting outreach and education and all the different missions kind of beyond that initial research focus. And at this point, we're effectively a clearinghouse of all things robotics, I would say, on campus. So we do K to 12 education via outreach. We do undergrad and grad courses and workshops and labs, executive training, professional development, research collaborations, industrial collaborations. We have a professional partnership program where not-for-profits and government organizations, companies, etc., can come in and benefit from our field of experts. So we have a team of staff, and then we support 50-ish professors on campus and their hundreds of grad students on their various projects that are kind of doing robotics and robotics related work. And then we also have a national research team where effectively anybody across the country who wants to do research with us or use some of our robots can kind of join our research team, and then they have access to our 70 plus robots, our high precision indoor positioning system, and all of the various kind of networking infrastructure, computer infrastructure, et cetera, that are kind of required to support all of that, along with a team of staff that are technicians and researchers in their own right across a number of fields between humanoid robotics, collaborative robotics, robots in health, in art, in architecture, in civil inspection, kind of mobile, fixed, all of the different flavors of robotics. We kind of do all of that, plus robot tech support, because that's not really a thing yet in the world.
Thank you. Thank you so much. So it would be great now if you could dive into some of the segments that we have seen in the video and perhaps start with assistive mobility robots. So those would be the ones that we've seen at the very top of the video: exoskeletons, walker augmenting robotics, the rehabilitation supports. These technologies are changing what recovery, elder care, and post-surgical pathways can look like. And so maybe Brandon, let's start with you first. What advances are we seeing in assistive mobility, and how close are they to being ready for daily clinical use?
So we're seeing a lot of advances, in particular with the application of sensing. So there's a number of companies, in town here that are using things like indoor positioning, things like magnetic resonance, and a couple of other kind of sensing modalities to actually figure out better ways to get information about the human body, to do better diagnoses. Hyperspectral imaging comes to mind. Um, and there's a lot of those aspects. There's actually a lot of technologies also being applied from, I will call it gaming systems, so virtual reality, augmented reality, etc., that we use a lot to try to figure out what's going on in our robots. And, in video games, you use to be more immersed in that environment. A lot of them are now being applied as well, both to provide kind of doctors and nurses and folks with more tools for diagnosis, for kind of getting a better sense of where things might be inside a person based on an MRI, based on a CAT scan, whatever it is, but also as controllers for some of these assistive devices. So whether it's an exoskeleton, um, we have a brain computer interface controlled wheelchair upstairs. So we're working on how does it navigate? How can you select objects that you might want to drive towards, or have the arm that's attached to the wheelchair pick things up, particularly when you have limited or no physical mobility. Maybe you only have eye control or facial control or one hand or something, right? So trying to figure out how to adapt accessibility controllers with video games and augmented reality and whatnot, that piece, and the actual motion control so that you're not walking into things or exoskeletons aren't falling down stairs and things like this. All of that kind of comes together into this package that has become kind of assistive robotics.
And how ready is it for clinical, daily clinical use? Like, are we there yet? Um,
So a lot of the sensors are being used in clinical use. And some of the predictive motion things, because a lot of robots need to know how people are moving, and you can use that to then determine if, let's say, someone is doing their physio. When they have to go home, they can strap something on that is generally used as a robotic sensor, and it will provide that data both for them as feedback of, you're doing the exercise properly or to the right motion, the right angle, etc., but then also feed that back to the physiotherapist or to their doctor, things like that. The wheelchairs, the augmented walkers, exoskeletons, some of them are ready. They are still large. They are still generally fairly expensive. So they're still going through that lovely process of how to make it so that, it's actually covered under health insurance and it's got all of the right, licensing and all of those fun things. Because there's also most robotics and most of these sensors are using some kind of wireless signal communication, something. And as you're all aware, putting things like that into a clinical setting, into a hospital, et cetera, has significant challenges attached to it.
so that's a great segue to Becky. Becky, from a hospital design perspective, what does it take to make spaces robot friendly for patients in spaces that do rehabilitation or long-term care?
Yeah, and I think this comment applies to all healthcare spaces. It's really about space. Do we have enough of it for these devices to be able to do what they need to do, navigate safely, give staff and patients enough, space to use them? But Brenda just hit on it. It's also about infrastructure. All of these things require a level of digital infrastructure that is, even beyond what we require in a healthcare organization now. They require things like charging spaces and different designs to let them go on elevators and all of those pieces. So it really is rethinking the design of a building from the ground up for how we make space for these things to work safety and effectively. And Brandon also mentioned it's also about affordability. So how are we making, good value add choices for what is really going to add value for patients and for staff in these spaces? And from a design perspective, Brandon hit on it as well. These are things that what does it mean for restorative care and getting these patients home and into the community in a different way? And so how do we need to start extending that design thinking even outside of the four walls of healthcare institutions? How do we need to start, thinking about how homes are designed and built to be able to accommodate some of these devices? Because if we can't have that use case extend beyond the patient's discharge, that's of course going to affect ultimate uptake and that equity and accessibility piece as well.
And this is a question for both of you. If you imagine Bren at university, and I know, Becky, you're way beyond just imagining it, as a living laboratory, what would it take to make mobility robotics part of everyday care, not just a showcase, but a reality?
I'll maybe start, Brandon, because I just have a thought. I mean, I think first and foremost, it has to be a value add, right, for the patient and for the clinicians. It can't be something that is a gimmick. It has to really have that value to the day-to-day, improving the lives of patients and staff. And, I think I would 10 years ago have said we're going to have a bit of an acceptable use hump to get over, but I think the generations are going to take care of that for us. But it has to be something that isn't just another thing for staff and patients to have to manage over the course of their day. It really has to bring something new to the conversation and add that value.
And then perhaps, Brandon, kind of seeing your facility, RoboHub, all the activities that you've outlined happen, and now we have a hospital that's on the campus. Like, sort of, what do you see as a possibility from research perspective, and kind of pushing the science further, enabled with the physical proximity of patients and providers and the physical structure itself?
Yeah, that's huge. We talk about it in our research projects. We talk about it in capstones when our fourth years are kind of doing their last kind of big thing before they graduate. Stakeholders are critical, and you have to make sure that the folks who are on the ground using it, whether it's the IT folks who have to support it on the infrastructure side, whether it's the operational folks who have to justify an ROI, whether it's the patients, it's the nurses, it's the doctors, it's the staff, everybody that's involved has to have some kind of say and some kind of information and some kind of understanding of what it can do, what it can't do, what it's going to impact. Is there additional, robots effectively are, computers with wheels or with arms and legs or some variation of that. They have all of the lovely benefits and all of the pain points of computers, plus they can move around and run into things, right? So there's all of the joys of cybersecurity and privacy and infrastructure and all of these things, and the mobility piece, right? So there's a lot going on that needs to be sorted out ahead of time. Retrofitting, so that the space that we have here, I want to say a quarter of our initial grant was just to build this space so that it would be as freeing as possible for us to do research in the space. And the big part of that was infrastructure, what the floors are, made of, and how we do wireless in here, all kinds of different things were kind of put into that design. So there's a lot of aspects on the infrastructure side that have to be there, and then there's the human aspect that needs to be there as well, for sure, right from day one.
Mm-hmm. It also speaks to me to the importance, perhaps, of a close collaboration between, people such as yourselves and people like Rebecca, who are thinking about hospitals, imagining, or more than imagining, really planning what will it take if robotics is the pathway we are pursuing. And I know that we are. So maybe, Becky, if you could speak to us a little bit to that, kind of what's going into the design of the new hospital to make it robotics ready.
Sure. So we're just entering our next stage of design this winter, but certainly our focus during the functional programming stage was, just as we talked about, making sure there is adequate space for all of the things that would need to be in place from that infrastructure standpoint to accommodate whatever that future state looks like. So making sure corridors are the correct, width and height. That digital infrastructure is in place. We have the charging and the separate elevator cores, and even thinking about things like from a workflow perspective, front of house versus back of house. Because as Brandon said, these are machines, but they run into things. So from a safety perspective, how do we make sure not only that we're not in any situations where, patients are potentially having to maneuver around, automated guided vehicles, but how do we also make sure those automated guided vehicles are able to do their job efficiently, unencumbered by additional navigation issues. So that is very much where we have started, is just ensuring that that space and infrastructure is in place and ready to receive whatever that future state might end up looking like.
Yeah, and I think one of the key things that we've seen when there's like retrofitting going on, particularly in hospitals and apartment buildings and things, is trying to figure out where those negative spaces are that people aren't, or that are generally, oh, we'll add in an extra closet here just because we have some space, or we'll add in a whatever. Some of those spaces, when you're designing and building these buildings, can be verticals, they can be data conduits, they can be, I've worked with a crew who they have a firefighting robot that attaches to the bottom of an elevator. So like if the elevator can lift up an extra 2 feet, then it can let this robot out to go fight a fire, but it's never in a space that people are going to be in, right? So it's finding those negative spaces in a design and figuring out where you could kind of store or charge or fix robots, right?
One type, maybe going over to the next segment we saw in the video, were cobots, or human robot collaboration robots. They're designed to work side by side with staff, assisting with workflows, prepping, handing off supplies. In healthcare, this could mean reducing burnout and freeing up clinicians for patient focused work, which is a probably one of the most dramatic pain points that as a healthcare system we are experiencing, but we're certainly not the only ones. I mean, this is a pain point experienced by healthcare systems around the world. So, Brandon, what are the biggest lessons from other industries, or from like manufacturing, for example, that healthcare can look to and adopt when it comes to cobots?
I think the biggest one is to look to the standards. So the major kind of robotics standard and the collaborative side of things just got updated, and they actually like this week they completely eliminated and removed the concept of a collaborative robot, and they've replaced it with collaborative applications for force sensing robots or torque sensing robots or whatever. Like they've separated it out because really it's those applications that are collaborative. It's not the robot itself, right? And one of the things that the standard makes very clear, and a lot of these application spaces, factories, warehouses, etc., is safety and standards are critical, and the interfaces between robots and computers, etc., and then the robots and the people are the critical piece. You have to get those interfaces right, whether it's how the person communicates, how the robot detects a person, all of those things have to be done right, and have to have defined behaviors that the people in those space know what that behavior is going to be. Because a lot of the time when we are walking past a person, working with a person, carrying a table with a person, all of that is based on how we assume they're going to move, act, react. We don't have those intuitive responses and understandings of these systems yet. So they have to be either predefined and very clear, or you have to spend time working with that system to know how it's going to react in those situations. And that's the most critical piece that we've seen across every industry.
With that said, how ready, sort of understanding the complexity of this healthcare as a domain, how ready do you think are we from a technology perspective for cobots in healthcare?
I think something like the mobile robots, so like the mobile manipulators, there's already some that have been deployed in various places, and I think there's enough understanding of how a system like that moves around that those are basically ready. Assuming all the licenses and approvals and all of the regulations and things are in place, those are basically ready because they also have had standards and safety protocols and things for wheeled systems for a very long time in industry. That's the ones that just got updated. So both for collaborative applications and also for mobile manipulators. Um, Anything beyond that, that's not, let's say, a sensor or a video game VR interface, something like that, that's already been through um, kind of commercial testing and consumer verification and things. Uh, it's ready for the lab. It's ready for a living lab kind of situation. They're not ready for deployment. So humanoids, anything on legs, they're most people don't know this, but there are literally no safety regulations or standards of any kind for any robot that isn't stable on at least three wheels and will only fall over if you like overload its payload rating. That's the only kind of robot system that currently has any kind of safety or standards defined. So anything beyond that is not ready for prime time yet.
Understanding that we're ways away, Becky, how do you see frontline staff changing, their roles changing if cobots are part of the new hospital from day one?
So I'll take it back to, we talked about that value add, and I think it's really about augmenting your frontline staff. It's not about replacing them, it's about freeing them up for the tasks that only a human can do. So how do we free up people to do people things like caring and doing that direct interaction with patients? And there's also huge potential, and this is actually one of the things that as we look at our conveyance and automation strategy, we actually want to study, because there's not a lot of literature out there, is how can cobots, automation and conveyance strategies, how can they support staff wellness through injury prevention? Because that is a huge source of lost hours, HHR challenges in healthcare, is those musculoskeletal injuries, because we're always pushing and pulling and heaving heavy things. And so what could that assisted mobility of supplies, what could that look like? And that's really where our focus has been so far in planning, is those conveyance strategies to stretch staff further. And a great example is, if a automated guided vehicle is able to get food trays up to the unit, your dietary team can focus on interacting with patients, making sure their menus are filled out, setting up their trays, supporting nutrition, which then has really positive patient outcomes. That skilled individual can be freed up from that transport aspect of their role. So those are some of the things that we're thinking about, is really how do you use this technology to stretch your staff, keep your staff healthier, and free up skilled people to do the skilled things that they are here to do.
That's a great segue to the next segment, which is logistics, robots delivering meds, linens, lab samples. These aren't glamorous, but they can transform efficiency and infection control. So, Brandon, what's technically possible today in autonomous logistics, and what are the remaining challenges?
So autonomous logistics is one of the most advanced pieces of robotics outside of, let's say, industrial manipulators that have been used on kind of assembly lines for a very long time. We've had dozens of companies with thousands of robots moving around factories and warehouses, moving stuff, doing point of pickup, point of delivery, filling shelves, and bringing shelves to people for picking, all of those things for a long time. And they're very good at avoiding contact. They're very good at navigating, building their map, especially when there's some kind of central control piece going on, so that there's kind of one brain making all the decisions. Most of the challenges that you see happening with autonomous systems, even wheeled systems and things, so like autonomous cars, anything like that, is because every one of those systems is thinking for itself and just making assumptions about every other system it sees or runs into or doesn't run into, etc. So in a space, I generally would call it like a closed campus type environment where it's a warehouse or it's a hospital or it's whatever. If all of the systems are connected into a common controller or even an organizer or an arbiter of some kind, that piece of the puzzle is actually very well advanced and ready, like right now for deployment across any number of spaces. The only space that I would say it's not quite um, ready for would be like sidewalks and things. So as soon as you get out into the real world and there's unpredictable animals, people, cars, branches falling, all of those things, right? If you're inside, if you're in a known environment, you have a map, there's a central coordinator somewhere, it's solid.
So Becky, perhaps a question where I'm hoping you could contrast for us sort of the reality of today versus the new build. If we were to pilot logistics robots that ran tomorrow, what would be the biggest hurdle? And then if you could contrast that with kind of what you're thinking about, because you've already addressed some of the things you keep in front of mind, but if you could kind of contrast that as to the new build and how that will change.
It really does come down to space. I think as one of the biggest barriers to implementation now. We could address some of the issues like the digital infrastructure to support the connectivity and things like that. But our corridors in our current sites are really narrow, and so now if we're introducing AGVs or other autonomous vehicles, things like that, we're running into those challenges of how do they navigate around all of those things. Brandon just said the people, the other vehicles, the things like that. And so that is, I think, our greatest barrier. And so again, as I say, planning for the new hospital has all started with space and making sure we have adequate space to enable those workflows, that separation of front of house, back of house, to really make sure that we're promoting safety, but we're also promoting that efficiency. And I think it's also thinking about how are we being, pragmatic and strategic and matching the automation solution to the need. We don't want to, over equip. So, to your point about sometimes we're maybe moving huge trays of supplies, but in some cases, maybe we're moving a couple of packets of meds. So how do we make sure we're also going with a strategy that matches those different use cases? So for right now, we're planning for a good old-fashioned pneumatic tube system, which have come a long way in the last several years. But for some of those smaller transport needs use cases, a pneumatic tube system is really all you need. We don't need necessarily an automated guided vehicle doing that work. So I think those are how we are mitigating. We don't know what is to come, but by making sure that those basics of space and infrastructure are in place, we're hoping to be ready for whatever that might look like in the future.
Mm-hmm. Brandon, from your perspective, what are some of the human barriers to robotics adoption in healthcare today? I mean, you mentioned you guys are developing, you have an interest in that particular field. If you could speak to sort of what you have encountered on the human.
Yeah, I mean, it really depends on if the people involved, as Becky was saying, see the value added, right? So generally, the people who are work there maybe see it, but maybe not customers, patients, etc., or the families of patients who have an entirely different set of opinions rather than the patients themselves. Often, really, it comes down to do they see the value in it, and is the opportunity cost to kind of pull in the economics of it, is the opportunity cost worth it effectively, right? Is it worth me having to stop in this hallway so that the robot can go by? Or is it worth me having to try to figure out how to interact with this thing so that it can tell me where to find the room I'm trying to get to, right? Whatever the purpose of that system is, there's the does it give me value and does it give me enough value to justify my time, learning, cost, whatever that thing is that you have to then contribute, right? You're usually going to get out what you put into a system, right? I think one of the most interesting things that we've seen is a lot of the social robots that are specifically designed to interact with people. They are built for specific spaces, specific audiences, specific tasks, and really the only commonality across them is that generally they're going to have some kind of face and some kind of voice interface. Everything else, it could be a massive thing with 20 legs. It could be just literally a face on a table. It can be everything in between. But the most effective ones are the ones that are very clear about their purpose. And I think it's one of Rodney Brooks' rules of robotics of like, if the robot doesn't do what it looks like it does, you have failed in building that robot. Like it's just full stop, right? And the curious piece is that I want to say it was Moravec, who's a Canadian in kind of the AI space with Brooks and Minsky and a bunch of them, that came up with the paradox of like things that are really hard for people or require a lot of education, a lot of kind of processing are very easy for computers and for AI, depending on what it is, and vice versa. So, advanced math, figuring out 30 moves in chess, whatever, all those things are easy for computers because computers are literally built to do those things. Whereas it's incredibly challenging to get a robot to do something like walk around and point at a bug that, a 1-year-old can do very easily, right? So there's very different pieces, and I think Becky said it of like the robots need to do the tasks that we either have repetitive strain or don't really want to do, or the things that we don't really need to be doing so that we can spend the time on the people stuff, right? We can do care, we can do interaction, we can help people, we can, all of those things. And the robots can carry pillows or wash laundry or, whatever the things are that we're like, I don't really.
Another interesting segment that we saw in the video at the top was remote presence and interaction. I think this one's particularly interesting as we are experiencing what is now a chronic shortage of people and resulting in difficulty, in accessing services, especially specialized services. So in this instance, robots can act as avatars for specialists, but also family members or even clinicians in other sites. So I mean, this to me really raises sort of an amazing potential what this could mean for rural or distributed care models. From your vantage point, Brandon, where do you see remote presence robotics adding the most value in the Canadian healthcare?
There's really two spaces that it makes a lot of sense. It's when you are up north or somewhere else remote and you need a specialist of some kind, particularly with some of the things that are coming online now with advanced networks where the latency is low enough. We actually have a project running right now with a company where we're trying to figure out if you can feel a texture remotely. So if you have a robot that has actual kind of touch sensors on it, and then you have a haptic glove or something, is there a way that you could actually like palpate someone's abdomen via a robot, something like that, right? So those kinds of things are going to be very technologically advanced and also benefit most folks who are not able to get to a specialist of some kind. The other the flip side of that is on the patient side, like you mentioned, where people will be able to talk to, their grandparents in long-term care or interact with a patient who might be in quarantine somewhere or, things where you can't get to the person physically, whether it's because of distance or medical reasons or whatever it is. You can then have an interaction that is as detailed or as kind of complex as whatever the system is that is there, right? So maybe it's just a robot that has a screen for a face and you're just, talking through a video call like we're doing right now. Maybe it also has arms. Maybe it's inflatable and it can give you a hug and it can feel how much pressure that grandma's giving you a hug through the whatever. It's entirely dependent on the quality of the technical implementation. But those are kind of the two where it's the specialist going remote or it's the family member kind of joining the patient remotely are the big ones.
I very excitedly noted your use of future tense. You kept saying will. So so are we headed for that future? Is how confident are you that we are?
I will say, and I will call out this crew for this. At the International Humanoids Conference every year for the last, I don't remember when it came out, but since Big Hero 6 came out, there has been a workshop every year at this very official academic conference, and the workshop is called Let's Build Baymax. And they have been working as hard as they can to try to figure out all of the technical challenges to build basically a like healthcare companion robot that is a big blow up, can't hurt anybody, that kind of system. And they've made significant progress, and there's an explosion of humanoids right now, and some of them will survive. Most of them are toys and marketing stunts, but some of them will survive. And some of the tools there are within will be able to make that happen. I would be very surprised if, for myself, maybe even for my parents, there isn't a companion robot, social robot, remote, play with the grandkids robot in a long-term care facility, hospital, etc.
Mhm. In designing the new hospital, Becky, how are you planning for a future where not every specialist has to be physically present?
Yeah, telepresence has come a long way, and just as Brandon said, like those are two big use cases. I think there's other huge use cases of when patients are already in a healthcare facility. But to your earlier point, Danita, our specialists are few and far between. So how do we have those specialists using their time efficiently? But from a cost perspective, how can we not be moving the patient to the specialist, but instead of the specialist to the patient? And even Brendan's point about, the sensors that are coming online to make those interactions so much more than just chats. Think about how much better cameras have even gotten year over year for the last decade, right? It used to be, when I nursed at the bedside, taking a picture of a wound on a 2 megapixel camera was sometimes not even enough for a specialist to be able to make, a really good assessment. And now we're all walking around with, 10 and 12 megapixel cameras in our pockets. So how can we just be leveraging that tech? And it might not even mean, a virtual presence robot. We're planning for terminals at each bedside. How do you get that quality of a camera right at the bedside so that specialist is able to join the patient right at the point of need? We don't even need the added kit of, bringing the robot around to have that virtual visit. There's also some cool emerging tech out there for putting specialists either in the hospital or in the community. So we've seen demos of these pods, which are, you can place them in malls, you can put them in City Hall, you can put them where your patients are, and it lets the patient complete a telepresence visit, privately and all of the things, but without having a phone and without having an internet connection. And if that, saves a trip into Emerge, how amazing would that be that you're able to, meet the patients where they are? And we even saw one that, as the visit is unfolding, a little drawer pops open and it's a thermometer or it's a blood pressure cuff, and it walks the patient through how to do some basic assessments. So again, when we're talking value add care at the point of need and, getting that care out of hospital into the community, there are huge opportunities for that telepresence and augmented virtual visit, for sure.
Last segment we saw in the video were precision robots, or surgical adjuncts, diagnostic tools, microinterventions. These raise big opportunities, but they also raise big questions. Brandon, what's realistic here for the near term, and where are we today versus the hype?
So I think where we are today, there's a lot of capacity and capability to do, I'll call it magnification. So something like a Da Vinci robot, any kind of surgical robot, etc. One of the main benefits they give you is not, it's that you can do things laparoscopically, great, but you could, if you had fine dexterity and great control, etc., you can do that by hand. The major thing that it gets you is that it can inherently and on demand do magnification of your force, of your motion, etc. So in that control space, the surgeon can turn up the resolution or turn down the resolution of their motion. So then, if they move 10 centimeters, maybe the probe moves 10 micrometers, right? You can get very, very specific. You can get very precise. Um, and even on a larger scale, not at that kind of micro scale, you can do that in the other direction as well, right? So you could potentially, a nurse hooks up into an exoskeleton and controls a robot that picks up a patient or a whole bed or, whatever, right? Like you can magnify the strength the other direction when necessary. Um, so I think magnification is definitely here. And particularly when it is directly controlled by people, really it's the sensors, it's the motors, it's the actuators, it's all of the bits and pieces that go into robots. They are ready now to be put into systems and used to magnify the dexterity, the strength, the resolution, whatever it might be of a person's motion and a person's kind of, I want to look at this. I want to see on a screen, the MRI slices all put stacked together into a 3D model. And then if I touch somewhere on the person, then the camera tells me where that is on the actual 3D image, right? All of those things are kind of today technologies. The critical piece, in order to enable some of the more advanced things that we're talking about, especially when it comes to micro robots in vitro, especially when it comes to precision control of more advanced, I will say, things that are not a probe through a laparoscopic hole or whatever it is the infrastructure that I am very thankful that Becky and team are putting into the hospital because we can actually now, try some of those things. Because without that infrastructure, there's not enough communication, there's not enough power, there's not, all of the various other things that need to be there to support some of the testing and verification of these tools so that they can then become something that's usable every day.
It raises a really important point for me that I have often illustrated with a mishap in one of the pilots that I participated in, where we were going to replace a human carrying laboratory samples by a transport robot. But before we had a chance to kind of design it in the pilot project with the help of our user experience researchers and designers, the team decided to sort of let it in the wild, and as luck would have it, there was a cold blue, and in the panic, no one could figure out where the button was to get the robot moving. They couldn't move. Anyways, all this to say the person was fine in the end, but this really put people off. And the result was the director of the laboratory saying, like, never again. And so it just goes to say that access, but if I can also sort of underline the role of a team like CareNext with that specific expertise, preparation, facilitation of communication so that we can understand all the pitfalls, will go a long way to help us design robots of the future, applicable and adoptable in healthcare. We have about 10 minutes left. This is usually the time where we go to our audience for questions, and apparently we already have a number of questions lined up. So it'd be great, Courtney, if you could share those with us. Okay, wonderful. So what is one of the biggest challenges in robotics today? Is it technical, political, economic, etc.? So I feel like this is for both of you. I know.
I mean, I can very easily tell you the largest challenge right now is legal, actually. So it's the ramifications, it's the regulations, and it's the responsibility. So if a robot does a thing, if a robot's in a space, whatever, who's responsible, and who gets to decide when they're allowed there, who's allowed there, who's allowed to operate, all of those things are not there for a lot of these technologies that we're talking about, which is why most of them just live in a lab or they live in a pilot project or they live, those kinds of things, right? The technology is there, people can see the value added of, hey, a person doesn't have to bend over and pick up this object 48 times a day. It's regulations, it's who's responsible if something bad happens. That's the challenge. It's the legal piece. And then the fun, ethical, and moral and all of the other aspects of like, should we and could we and why are we, all of those come into play as well. But the actual challenge for the robotics folks is, legally, how does this work? What happens? Who's in charge? Yeah, that's the major one.
And Becky, maybe from your perspective, sort of like from the hospital slant or healthcare slant, where do you see the biggest challenges?
I think it is all of the things Brandon just said, but how those translate into cost and establishing your business case. Like that's really, Brandon hit on it earlier, talking about opportunity cost and how do you sell this as, we want this robot instead of this, because those are always the choices we're faced with in healthcare. So when it comes down to establishing a really solid business case for the return on investment for this stuff, all of those other things that Brandon just described just mean that there's not a lot of places you can look to say in the healthcare sector, here's how it worked amazingly. And so we can look to other industries for sure. But again, for all of those reasons Brandon just mentioned, those aren't always readily translatable when you throw the medical, legal, ethical, all of those crunchy pieces into the mix.
I feel like this one is for you, Brandon. Have there been any surprising or counterintuitive discoveries made as a result of research and data collection in a healthcare space?
I did see a very interesting one recently. So we have a number of teams on campus that look at and like one of the founders of the whole field of social robotics is actually on campus, Professor Kirsten Dottenhahn. But we have a number of people who look at kind of the social aspects, how they interact with kids, with folks in long-term care facilities, physical human-robot interaction, things like that. And every time we talk to folks in the healthcare space, in long-term care, any of those kinds of things, the appearance and the materials and the colors and the textures of the robots play a significant role in what people think the robot is going to be good at or can do. To the point of like, a Paro robot, for example, which is kind of like a seal that will kind of wiggle and purr if you pet it, which is for companionship and kind of replacing something like a pet, but you don't have to feed it or, all of those fun things. When it's looked at, it's treated very differently than if you had, let's say, like a white plastic, 1 foot tall humanoid or something, even if it responds exactly the same way to your behavior. And vice versa, if you have something on a desk that looks like a screen versus you have something roaming around, etc., the actual appearance, the texture, is it fuzzy, is it smooth, is it shiny, is there metal pieces, all of those things have way more of an effect on what people think the robot can do and what they think it's capable of doing is the other weird one, than what it actually does, can do, demonstrates, etc. There is a huge like first impression before it makes any noise, before it actually moves aspect that does not go away once it starts doing something. Again, it comes back to Brooks' rule, right? If it starts doing something entirely different than what it looks like, it has failed. Your design has failed.
Kaylin has two questions for us. So first one, she's sort of linking hospital beds and automated, or I guess driverless cars. So she's saying, how do you control the hospital beds to communicate with each other? I've seen many videos of automated cars in parking lots causing issues and accidents. Do you think this could happen with the beds?
I don't, and mainly because, like I mentioned earlier, those cars are all thinking for themselves and making assumptions about everything else in the space. In a hospital, all of the beds, robots, sensors, etc., will have a central coordination tool, hub, maybe central controller, and there's the possibility and potential to actually have something that is privacy maintaining, but that provides a physical map of the inside, like a digital twin almost of the hospital, where you could use something like laser scanners or presence sensors, things like that, to be like, oh, there's 5 people in this hallway, take a different hallway. So you can actually do a lot of that larger scale planning when it's, again, that closed campus type of space.
Her second question, I think this one is for both of you. Maybe Becky, if you could take it. It sounds like understanding the service model of each team is important. How do you manage and understand the hyper-specific team priorities and translate them into more general robotic outputs? So before I even let it, I'm going to say, well, this is where your CareNext team comes into play, right? We have brought in the capacity to help gather exactly this type of information and facilitate the conversation between clinicians, patients, their families, and researchers and or innovators designing in this space. So I would say really the way you do it is that you sort of have to embed yourself in the context and understand the context really well, and then ensure that there's a common language and common understanding, and the way that the information flows between those who are experiencing and providing care and those who are creating solutions is well understood. And so from my perspective, that user interaction is incredibly important, and your CareNext team is bringing exactly the skill set to sort of facilitate that. Maybe over to you too.
Yeah, and I'll just maybe tie it even to the previous question, because the answer to, how advanced do you think things will be? Well, that's, to be determined. We don't necessarily entirely know what that's going to look like. So on the one side, it's making sure we have that infrastructure in place. But then to your point, Danina, it's, how do we spend the next 7, 8, 10 years working in partnership to understand those specific needs? And I think it ties back to what we just talked about around, navigating that regulatory and medical legal, and how do we make those business cases, and all of those pieces to tie it back, because, again, at the end of the day, there is hard cost to all of this. And so how do we make sure we're making good decisions that are value add for the organization and value add for our community and patients and staff?
Thank you for that. Okay, so we have about 3 minutes left. So maybe one last question before we start wrapping up. And this one feels like a great way to conclude. By the time the new REN site opens, which is about a decade in the future, how advanced do you think robotics will be in surgery, clinical care, diagnostics, and administrative logistics? And maybe I'll add just a little sub question of my own. Which robotics use cases feel closest to becoming mainstream in Canadian hospitals? So maybe over to you both for.
So I know, any prediction you make about robotics will be wrong within but I will say that we actually have an event coming up the beginning of November 12th, that we're running, which is looking specifically at kind of how robotics and robotics adjacent technologies, sensors, things like that, are going to impact healthcare, and how healthcare is already using a lot of those things. So if you're interested in joining that conversation, then please join us there. But I will say, I think by the time the new REN opens in 10 years-ish, I think a lot of the aspects of these spaces across all of the various healthcare verticals are going to have significant enough automation that the people can focus on the things that people do best. So the things that surgeons have trained for, and that diagnosticians have trained for, clinicians have trained for, etc., they're going to be able to do their jobs faster, more efficiently. They're not going to have to do repetitive tasks, things like that, whether that is via some flavor of AI, whether that's via a robot, whether that's via some kind of automation. The modern day equivalent of I'd say like Victorian times, where you had a separate staircase and a dumbwaiter that lifted food up to a particular location, all the things where it's like built into the infrastructure of our society. I think there's going to be a lot of that across the board, not just in healthcare, but kind of everywhere. And it's going to be a matter of figuring out what humans do best, because that's what we are going to continue to be doing for a very long time.
Well, with that, let me say thank you both to Brandon and Becky for bringing both vision and pragmatism into this discussion. To all of you, our participants, robotics adoption isn't about gadgets. It's about redesigning systems, spaces, and cultures to make healthcare more capable. We'll share today's recording and resources afterwards. If you're interested in co-development with RoboHub or want to explore how robotics might address challenges in your department, please reach out to CareNext. For those interested in the topic, RoboHub, as Brandon has mentioned, is organizing a symposium which you will not want to miss. Please, Brandon, if you could maybe just point people to where they can find information about this before we leave. And finally, thank you for participating, and join us next month as we continue the collective conversation. Thank you for spending your hour with us. And as ever, thank you to our presenting sponsor, Manulife Canada, for supporting this ongoing conversation.
Yeah, thanks, folks. If you want details about that, it's just at uwaterloo.ca/robohub/events. It'll be up there. It's our fall symposium.
Thank you all.